Hello, everyone, and welcome to our webinar today. My name is Dr. Devin Mackay. I'm the Director of Neuro-Ophthalmology at Indiana University in the United States. And today we're going to be talking about idiopathic intracranial hypertension and some common challenges and misconceptions. This is a very common condition that I see in my clinic, and I see a lot of confusion out in the community about how to manage these patients and what are the best ways to treat them. So we're going to be talking about that today. I have no relevant financial disclosures. So our objectives today, one is to understand how the number of radiographic signs of intracranial hypertension that someone would find on an MRI influences the likelihood of finding papilledema. We're going to talk about the data on the medical management of IIH and several surgical options, including venous sinus stenting, which is relatively new. Also, we'll discuss what to do when a patient with IIH improves in every way except for headaches. Understand how pregnancy planning impacts the management of IIH. We're going to introduce the concept of idiopathic intracranial hypertension without papilledema and know what to do with those patients. And also recognize fulminant IIH and what that is and be able to facilitate urgent management of such a patient to save their vision. First, let's talk about some of the symptoms that are typical for IIH. Of course, headaches is the most common symptom, and almost everyone has headaches. About 94% of patients with IIH have headaches. The headaches may or may not be worse when they're lying down. Sometimes when it is worse when lying down, that can be a vote that high pressure is causing that headache. And then the headache may also improve immediately after a lumbar puncture. Pulsatile tinnitus is also fairly common. About 58% of patients have it. And they describe it typically as a whooshing sound in the ears that is synchronous with their pulse. It's often like a whoosh, whoosh, whoosh. Transient visual obscurations are also common in about 68% of patients, and those we'll see in patients with typically with moderate to severe papilledema, usually not mild papilledema. And the way I ask patients about this is I say, does your vision ever gray out or black out when you bend over, cough, or sneeze? Diplopia is less common, about 38% of patients, and that can happen from unilateral or bilateral sixth nerve palsies. Changes in weight are important, especially rapid weight gain more than someone's absolute weight. And then nausea and vomiting can be present in really acutely severe elevated intracranial pressure. And then, of course, some patients may be asymptomatic, so that does happen as well. Now, papilledema is the most important finding when someone has IIH. And the higher the grade of papilledema that is found, the higher the risk is of permanent vision damage. And papilledema can be somewhat quantified on the Friesen grading scale, which we see here to the right. We see the different grades. And so I tend to document that, and I hope others do too. I think it's a nice way to quantify things in a way that is replicable and communicate between different people that way as well. Optic nerve structure and function are the most important things for us to assess in IIH. And so those really have to be monitored. And so visual field testing is especially important, and looking at the optic nerve head and seeing what the grade of papilledema is. Those are the two most important things. And then we also check, of course, color vision and visual acuity and other measures of optic nerve function. So one of our pearls that I want you to take from this webinar today is that a higher opening pressure measurement on a lumbar puncture does not automatically mean that the patient has a higher risk of vision loss. So in other words, the absolute opening pressure measurement doesn't determine whether someone is high or low risk for vision loss. What does determine that is how severe the papilledema is. So visual field progression, how does the visual field worsen typically in patients with IIH? That's worth knowing about. And the vision loss progresses a lot like glaucoma from the outside in. And so for that reason, patients may not notice that the vision loss is happening. Remember that central vision loss in IIH indicates very severe vision dysfunction. It's usually the last thing to go when someone has IIH. And so here's a typical progression of visual field abnormalities with this condition. Enlargement of the blind spot is often the first thing that we see, followed by a nasal step or an arcuate defect, and then visual field constriction. And then the very final part to go is the very center part of the vision. Remember, central vision defects are very uncommon, especially early in IIH. If you have an early, fairly mild case where central vision loss is the predominant part of the presentation, we want to think about other diagnoses in that kind of a case. Now, one hot topic that's come up over the past few years is radiographic signs of intracranial hypertension. So how often have you seen this phrase in your radiology reports? So this is an actual patient that I saw, and this was the report. Partially empty sella with bilateral transverse sinus narrowing, non-specific finding which can be seen with, but not diagnostic of intracranial hypertension. And then correlation is advised and evaluate for papilledema. So what do we do with this? Does this mean every patient who has that in their radiology report needs a lumbar puncture and needs to we need to assume they have IIH? Well, not exactly. So it turns out, well, before I go into that, let's take a moment for a poll. I would love to know from each of you, how often are you referred patients because the radiologist read an MRI as showing signs of intracranial hypertension? So is that very frequently, A, fairly frequently, B, pretty rarely, C, or never? That's no one's ever referred to you for that. So I would love to hear your responses. We'll give about 30 seconds for everyone to respond, and we'll see what the results are. Okay, so we have people in the kind of the fairly frequently to rarely categories were most common, and then very frequently a few and never a few. Okay, well, good. That's really been our experience here as well. So it's good to see that carries elsewhere. So to answer this question about how concerned do we need to be when patients have these radiographic signs of intracranial hypertension, there's a really nice study I want to call some attention to that was published in JAMA Neurology back in 2021, looking at the prevalence of incidentally detected signs of intracranial hypertension on MRI and their association with papilledema. So for this study, they took almost 300 patients who had MRIs for any reason at all, and they took them all consecutively. And then they asked a neuroradiologist to look for 10 different radiographic signs of intracranial hypertension. So here's a few of them here. One is distal transverse sinus stenosis. Another is optic nerve head protrusion into the globe. Another is increased CSF space around the optic nerve, which you see as the white ring around the optic nerve there. An empty sella turcica. Cerebellar tonsillar ectopia, which is where the cerebellar tonsils descend below the foramen magnum. And I will point that out with my laser pointer here. So here's the cerebellar tonsils, and if they go below that line, which is at the base of the skull, at the foramen magnum, then that cerebellar tonsillar ectopia. And posterior scleral flattening, so if the posterior part of the globe is flat, and there are a few other signs as well. So all of these patients underwent fundus photography with non-mydriatic fundus cameras. And then those with abnormal photographs were also evaluated by a neuro-ophthalmologist in person to confirm papilledema. And out of these almost 300 patients, they found 5 who had papilledema. And they also looked at the signs of intracranial hypertension. And if someone had one sign of intracranial hypertension or more on their MRI, about 2.8% of those patients had papilledema. So that's not very impressive. So if someone had just an empty sella, for example, their likelihood of having papilledema was about 3%, quite low. If patients had more signs of intracranial hypertension, so if they had 4 or more of the 10 signs, then the prevalence went up quite a bit. So about 40% of those patients who had 4 or more signs of intracranial hypertension. So the most common sign in this series was an empty sella. About a third of patients have an empty sella. That's amazing for any reason at all. So 300 MRIs done consecutively for any reason at all, about a third of those had an empty sella. So it's a very, very common finding. But remember, only 5 out of these 300 had papilledema. So there's a lot of patients with empty cellas who do not have papilledema. And of these 5, 2 of them already had a known history of IIH, 2 had a structural lesion, a glioblastoma, and 1 had a temporal lobe seizure disorder from an encephalocele. So when patients had more radiographic signs of intracranial hypertension, then they were more likely to have papilledema. Remember, only about 3%, if they had one sign of intracranial hypertension, had papilledema. And so it's very unusual to diagnose IIH just from the MRI and have that be a meaningful diagnosis. It's very, very rare. So what do we learn from this? Well, if someone only has one sign of intracranial hypertension, it's very rare that that will be associated with papilledema. And looking for radiographic signs can be a factor in estimating how likely it is that a patient may have papilledema, but it doesn't mean that all of these patients have IIH. And those with papilledema were detected in this study with fundus photography without pupillary dilation. And so here's an example of a non-mydriatic fundus photo. This was taken of my own eye. And this is probably going to be the future of fundoscopy. For now, direct ophthalmoscopy is still very useful, and it's used in a lot of places, and especially places where we can't bring other equipment very easily. But fundus photography with cameras like we see here are going to be part of the future. I typically teach others who are not ophthalmologists, when they come across these findings on an MRI report, I have them ask the patient, when was your last eye exam? If they had a recent eye examination that showed no papilledema, then there's typically no cause for concern. If there was papilledema, then obviously they get evaluated as if they may have IIH or some other cause of intracranial hypertension. All right, now let's shift gears a little bit and let's talk about the medical management of IIH. The best data we have for the medical management of IIH comes from the IIH treatment trial, which was published in the Journal of the American Medical Association, JAMA, in 2014. And so here, let's go over the results of that trial. So they took 165 patients with IIH and mild visual loss, and they randomized them to either a weight reduction, low sodium diet plus acetazolamide, or that same diet plus placebo. So both groups were treated with the diet. And the primary outcome was improvement in the visual field. And I was very happy about that because visual field function is the most important outcome in IIH. So acetazolamide was better than placebo in a few things, in improving visual fields, in improving papilledema, and also in improving vision-related quality of life. However, there were some things that acetazolamide was not better at doing, and that was improving headaches, interestingly, and also improving visual acuity. The visual acuity part is not too surprising because remember, these were patients with mild visual loss, and if we remember earlier, central vision loss, which is where visual acuity would be, is very uncommon on IIH unless it's really advanced IIH. So acetazolamide has our best evidence for efficacy in IIH. And how I usually prescribe it is in total daily doses up to as much as 4,000 milligrams a day. So usually I divide it twice daily. You can divide it more frequently, like 3 times or 4 times daily if a patient has difficulty with tolerating the medication, and that could be a helpful change. In terms of a starting dose, I usually start at a dose of about 500 milligrams twice daily. And then from there, I titrate. If the patient has really severe papilledema, I'll titrate up quickly to a higher dose. If they have minimal papilledema and minimal symptoms, then I'll stay there or maybe even go lower if they have difficulty tolerating the medication due to side effects. So what are those side effects? Most patients describe a change in the taste of carbonated beverages. So sodas taste bitter to them, they tell me. Also, tingling of the hands and feet is a very common side effect. I'd say most patients have that. And then some patients have lethargy or other side effects. Now, weaker evidence exists for the use of topiramate, and that's class 2 evidence. It is also a carbonic anhydrase inhibitor similar to acetazolamide, although it works a little bit differently. It has some added benefits of serving as also a prophylactic agent for migraine. And so if you think a patient may have comorbid migraine, it can still be a good choice. And also there may be a little bit of a side effect of weight loss in some patients with who take topiramate. So it can be helpful for that, but still the evidence for its efficacy in IIH is still not quite as good as acetazolamide. We have better evidence for acetazolamide. And then some physicians use furosemide as well. That is a poorly studied medication in IIH, considered a class 4 evidence. It can still be helpful if someone's really wanting to avoid surgery and really everything else has failed. It can still be a useful medication in some cases. Now, what do we do with the side effect of nephrolithiasis or kidney stones? So this was something that was studied in the past, and in this particular study, they looked at the charts of 670 patients who had IIH, and this was a case control study. They found that almost 3%, so 19 patients developed a kidney stone during acetazolamide treatment for IIH, and that's a known side effect of IIH. And so what do we learn about that? Well, about 90% of those who developed a kidney stone did so within the first year and a half of treatment. And there was no association between the daily dose and stone development. In other words, if someone was on a higher dose of acetazolamide, that did not equal a higher risk of having kidney stones. Also, the longer you're on the medication, so if it if, let's say, 5 years you're on the medicine versus a couple of years, there's not much of a difference there either, because the first year and a half is the biggest risk for nephrolithiasis. So if you're going to get it, it's usually going to be within that first year and a half. So this has helped frame what I tell patients about the risk of kidney stones when they're being medically treated for IIH with acetazolamide. So most of that risk is in that first year and a half. And then it doesn't matter if we're on 2,000 milligrams twice a day or 500 twice a day. There does not appear to be a difference in the risk of nephrolithiasis with those doses between different doses. Now, another thing that has come up in quite a few of my patients has been the issue of a sulfa allergy. And so, as you know, there's a moiety on acetazolamide that is a sulfa moiety, and so there can be some cross reactivity. Has been the thought with patients who have a sulfa allergy, and that they may also be allergic to acetazolamide. And so, does that mean we can't use acetazolamide in patients who have a sulfa allergy? So someone actually looked at this. So Andy Lee and Michael Wall and group at Iowa looked at this and found that they looked at 363 patients with IIH, and they found that almost 10% had a self-reported sulfa allergy, so about 34. 27 of those patients were treated with acetazolamide, 21 were treated with furosemide, and 14 were treated with both of those, and that's why the numbers add up to more than 34. And then none of the patients treated with either acetazolamide or furosemide had a severe allergic reaction to the medication. So that was really helpful. And so what I take home from this is that it's okay to use acetazolamide or furosemide in patients who have a self-reported sulfa allergy if you need it in IIH. So I don't let the self-reported sulfa allergy block me from trying the medication. In fact, I still convince most patients to still take acetazolamide when it's necessary. If someone has a history of a very severe anaphylactic reaction to sulfa, that might make me think twice. But if it's something like hives or a rash or GI intolerance or something like that, I will still push for acetazolamide, because again, it really is the best medication that we have for the medical management of IIH. And weight loss is also a cornerstone of the medical management of IIH. This study was fairly recently published in 2022 and looked at the amount of weight lost after bariatric surgery in patients with IIH, and kind of seeing how much weight loss is enough in these patients. So this looked at 66 women in the United Kingdom with IIH who had a BMI of greater than 35, and they randomized them to either treatment with bariatric surgery or community weight management intervention. 23 of the 66 underwent bariatric surgery, and they found that a loss of 24% of the body weight was associated with IIH remission. So it went away when someone lost that much weight in this study. So does that mean that we need to recommend someone lose about a quarter of their body weight for IIH? That seems like a lot. That's about 60 pounds for a 250-pound person. And it's kind of hard to get that kind of weight loss with unless you're doing something like bariatric surgery. And previous data suggested that maybe 6 to 10% weight loss was enough to really make a big difference with this condition. We have to remember too that these data were for weight loss without acetazolamide use. And so it may be different when someone's on acetazolamide. Perhaps they don't need to lose quite as much weight when that's the case. But it still goes to show us that there's an amount of weight loss that is helpful for these patients. That exact amount of weight is different for every patient, and I never give someone a specific target weight of a number. We just encourage them to work on weight loss as best they can at a rate of maybe 1 or 2 pounds a week, and we try to keep it that way. Now, what about pregnancy planning in IIH? So it turns out that oral contraceptives are not contraindicated in IIH. There has been an association between OCPs and IIH suggested by some case reports. However, multiple studies have shown that there is no increased risk of IIH from OCP use. OCPs with higher estrogen doses in the past were associated with weight gain, and that may have been a mechanism by which IIH was slightly more prevalent in patients on those OCPs from the past. However, the OCP estrogen levels are much lower now, and they're not associated with weight gain. This was a great study done out of the Mayo Clinic, and it was a population-based study looking at the association between hormonal contraceptives, including oral contraceptives, and idiopathic intracranial hypertension. And they looked at patients with IIH diagnosed in this period And they have access to all of the patients with medical records in their county. And so they're able to make nice population-based studies like this. And they found 53 patients with IIH. 21% had used hormonal contraceptives within 30 days of diagnosis, and about 31% of the control patients had used a hormonal contraceptive. And they found that the odds ratio, so in other words, the risk of OCP kind of leading to IIH was 0.52, so much less than 1. So there was not an increased risk in patients on OCPs of developing IIH. And this was mostly oral contraceptive pills in the study, but other hormonal contraceptives were included as well. And so our take-home message from this: oral contraceptive use does not lead to intracranial hypertension. So you don't need to take patients off of that. I still see that as a myth floating around out there, that we need to get everyone off of OCPs if they may have IIH, or that they may develop it if they're on those. And the answer is no, that is not correct. Now, what do you do when someone is pregnant and they have IIH and it's been confirmed and you need to treat them? What do we do in those cases? Well, acetazolamide is listed as a pregnancy category C medication, which means that we don't have data definitively proving that it's safe or harmful. However, there are 2 studies that were done that show some class 4 evidence supporting acetazolamide as a safe treatment for IIH in pregnancy. One of those was an observational case series that was very small with 12 patients, and they found no adverse pregnancy outcomes in those 12 patients. A larger study of a survey of 158 pregnancies, and about 50 of those were in the first trimester, showed no major complications in offspring of women treated with acetazolamide. We've also asked in an informal setting among neuro-ophthalmologists at national meetings and trying to see, has anyone had any significant cases of birth defects from IIH, and we really haven't found any. And so certainly excessive use of acetazolamide should be avoided during pregnancy, but if the medication is necessary, then it is an option, and I do use it routinely in patients who are pregnant and have IIH. Topiramate, however, should not be used. It is teratogenic, and so do not use topiramate in pregnancy, but acetazolamide is okay when necessary. Now let's talk a little bit about how to deal with headaches. You may think, well, I'm an eye doctor, I don't need to deal with headaches. Well, your patients will still come in with this, and we still need to figure out, do I need to treat the IIH to get rid of the headache? So patients, let's examine a case here. So a 25-year-old woman with IIH who was first diagnosed 2 years ago with papilledema and good visual function comes to see you. And she initially had classic symptoms of headaches, pulsatile tinnitus, and transient visual obscurations. She lost about 10% of her body weight and was treated with acetazolamide at doses up to 2,000 milligrams twice a day, so high dose. And she had resolution of most of her symptoms. So the papilledema went away, her transient visual obscurations, and her pulsatile tinnitus. However, her headaches recently returned. So does that mean that her intracranial pressure went up again? Is that what happened? So how do we know what to do with these patients? Well, let's take a step back and understand a little bit about the pathophysiology of headache in IIH, and that'll help us know what to do with this patient. So the cerebral veins and meninges are the pain-sensitive intracranial structures. Remember, the brain is not pain-sensitive itself. So venous sinus stenosis and increased venous pressure that is present in many IIH patients may be a source of pain. And pressure on the meninges also activates the release of nociceptors in meningeal blood vessels, and that's one of the mechanisms by which pain develops. And this can lead to a cascade of events in the trigeminal vascular system and its central projections, which is similar to the pathophysiology of migraine in some ways. And during a headache, these meningeal nociceptors and the peripheral trigeminal system may become sensitized because it's activated a lot, and a kind of an abnormal feedback mechanism can develop, and patients can have dysfunctional pain modulation as a result. And if that has happened, then lowering the ICP may have little effect on headache pain, even if the headache initially was from high pressure. So again, this dysfunctional pain modulation that happens after chronic headache can sometimes change the effect. If you were to lower the ICP again, maybe it won't have the same beneficial effect. So then what do we do with these patients who have headaches and IIH? There was a nice review by Deb Friedman in the Journal of Neuro-Ophthalmology in 2019 that went over this very issue. And she noted that about two-thirds of IIH patients continue to have headaches even after their papilledema goes away and other symptoms of IIH resolve. And so early in the course of IIH, CSF pressure lowering agents are the first line treatment for these headaches. And then you can do adjunctive agents as needed. But after the resolution of the other signs and symptoms of IH, let's say their papilledema goes away and they're otherwise doing well, but the headaches are still there, then it's really a headache-based strategy, and that's based on the headache phenotype. So in other words, is this a migraine? Is this a tension headache? Is this some other headache disorder? And treating the headaches that way without regard to the intracranial hypertension. And so that's a big mistake I see, is that someone's headaches come back and automatically it's assumed that the IIH is the cause. And it may not be. It may have been the initial cause, but it may not be the current cause. And so in those patients who just have headache and nothing else, no papilledema, those patients need to be treated phenotypically for their headaches, and that can be done with a neurologist. So this kind of summarizes what I just mentioned. And so determine that headache phenotype and treat it as such. And again, that can be something that a neurologist can do. So take-home message from that is treat according to the headache phenotype. When someone has chronic headaches and IIH and they've had their other symptoms and signs go away. So don't try to lower the intracranial pressure as the treatment for that. Now, what about IIH without papilledema? What do we do with those patients? Well, it turns out this is a recognized entity, and it does share much of the same diagnostic criteria that are used for IIH with papilledema, with a notable exception. They either have to have one of two additional things. They either have to have a 6-nerve palsy or have 3 out of 4 imaging findings of intracranial hypertension. So those are highlighted here. So of the 4 that were chosen, empty sella, flattening of the posterior globe, distension of the optic nerve sheaths, and transverse sinus stenosis. If they have at least 3 out of 4 of those and have all of the other criteria for IIH, then they meet the diagnostic criteria. Or if they have a 6-nerve palsy, plus all the other diagnostic criteria, that would also work. So in other words, it's not enough to just have an opening pressure that's high on a lumbar puncture. That does not give you a diagnosis of IH without papilledema. You have to have the radiographic findings as well, or a 6-nerve palsy. Now, what do we do with these patients? If they don't have papilledema, can they still lose vision from IIH? The answer is no, they cannot. So that is a very, very important detail. This has been studied in the past. So patients who do not have papilledema and they have IIH, they are not at risk for vision loss. It really becomes an issue of headache management and trying to control their symptoms. And that can still be done with acetazolamide and the other typical treatments, but the issue then is not vision risk. And so that's typically managed by, probably not by an ophthalmologist at that point. So why even diagnose that? Who cares if they can't lose vision? Then why do we care about IIH without papilledema? Well, it does clarify some potential ways to treat them for their high intracranial pressure symptoms. So their headaches or pulsatile tinnitus, we know how to treat that if we know that it's from high pressure. There can also be an association with spontaneous CSF leaks if patients have chronically elevated intracranial pressure. So we don't want to completely ignore that. It may be important to treat those patients to help prevent CSF leaks, although we don't have data to definitely confirm that yet. So it helps provide security of the patient having a diagnosis. That helps them have some security in knowing what to do to help their symptoms. It helps motivate weight loss in many cases, and so it can be useful in that regard as well. Now, what about fulminant idiopathic intracranial hypertension? So that is IIH, where a patient has intracranial hypertension with no secondary cause, and they have severe vision loss within 4 weeks of symptom onset. And that progressive vision loss usually develops over days. So it's very fast. I think of it as a very, very severe case of IIH where the vision loss is presenting early and it's swift. And so these are patients that we need to intervene on quickly. So these patients need urgent treatment. And they're at high risk for permanent vision loss if we don't treat them urgently. And this is estimated to maybe be about 2 or 3% of patients with IIH have this fulminant variety. And it's definitely worth knowing about them because we can help save their vision if we intervene quickly on them. So how do we recognize fulminant IIH when it happens? Well, one series looked at a series of 16 patients with this and tried to figure out, okay, what are the symptoms that these patients present with? One thing that was interesting about that series is that about 56% of the patients in that series presented with nausea with recurrent vomiting, and that's not typical for IIH. So if you have someone that's got really severe vomiting as part of their IIH, that might tip us off that maybe this could be a fulminant case. Um, and then the majority of patients, so 81% had subjective subacute vision loss. So these are patients that are recognizing that their vision is bad pretty early on in the course. So again, within that first 4 weeks. Quite a few had neck stiffness as well, about 25%. I do hear about that in patients who don't have fulminant IIH as well, but it's not very common. So if there's a prominent neck stiffness with any of these other symptoms, then you may want to think about fulminant IIH. And then all of these patients should have severe papilledema. So it should not be subtle papilledema. It should be very severe, sight-threatening papilledema. These patients should have neuroimaging performed urgently if they haven't already, so an MRI of the brain, and they should also have a lumbar puncture quickly to secure the diagnosis, make sure that's really the diagnosis. And then also the lumbar puncture can provide at least some very temporary decrease in the intracranial pressure, even though that does not last very long. Sometimes that can be helpful in providing a little relief for the patient and also some time to plan for a surgical procedure if needed, or starting aggressive medical management if it's appropriate to do so. And fulminant IH is managed with a combination of medical and surgical interventions. And so in these patients, I start them on acetazolamide as soon as possible, and I get them up to a high dose very quickly. And that's regardless of what else we do. We always want to do that as a first step. And then we may want to consider urgent surgical intervention depending on the case. So in other words, if we don't have time for medical management to do its work because we're already losing vision very quickly, then we don't have time for medical management. We need to go to surgery in those cases. Some patients can be treated with IV methylprednisolone as a temporizing measure if they're awaiting surgery and their vision is getting bad. You know, we need to wait a couple of days for surgery for some reason. Sometimes IV methylprednisolone may be an option in cases like that, even though we don't have great evidence for its efficacy. If the delay in surgery and they need surgery is more than a 24-hour delay, then you can consider things like a lumbar drain. That's kind of a temporary shunt in a way. Ventricular drain would be the same thing, like an external ventricular drain, or even serial lumbar punctures. I don't advocate for that unless they're in the hospital and you're literally waiting for surgery and you can't do a lumbar drain for some reason. Maybe that might be an indication, but otherwise serial lumbar punctures are usually not the way to manage intracranial hypertension. And then for surgical options, we have three main options currently: CSF shunt procedure, optic nerve sheath fenestration, and venous sinus stenting are the kind of the three major ones, in addition to a weight loss surgery of some kind. But these are the three that we choose from. So how do you know which one to recommend? Let's say you have a patient who needs surgery. How do you know which one to do? Well, let's get a poll here first. So I would love to hear from you about what surgical procedure have you most commonly recommended for IIH when it's necessary? So have you recommended a CSF shunt, like a ventriculoperitoneal shunt or lumboperitoneal shunt, or an optic nerve sheath fenestration, or a venous sinus stent, or bariatric surgery? Okay, so it looks like the vast majority have been CSF shunt, and then a fewer number for optic nerve sheath fenestration, very few for venous sinus stenting and for bariatric surgery. So that's an interesting mix, and not too surprising. So let's talk about kind of how to choose among those different options. So let's look at that. First, we need to understand, how do we know when a patient needs surgery? If they have IIH, how do you know when they need surgery? Well, there are no universally agreed upon criteria. So that's first thing to know. But the most important thing is always visual loss. So visual loss is the most important criterion in deciding whether someone needs surgery. So here's some reasonable criteria for treatment of IIH surgically. What I would consider strong criteria is progressive vision loss despite maximum medical therapy, and then also significant vision loss on first presentation. In other words, fulminant IIH. Those would be strong indications for surgery. Less strong would be if they have some vision loss, but you can't follow it for some reason. And that may be because they have cognitive impairment or can't do visual field testing for some reason, or something like that. And maybe they have severe papilledema. Or intractable headaches that respond to lumbar punctures. even though their vision's okay. That's a much more controversial indication, which is why it's less strong. So what are those surgical options? We just talked about that a little bit ago. So one is doing a ventriculoperitoneal or LP shunt. It sounds like that's the most commonly recommended one among our group here today. And then optic nerve sheath fenestration and venous sinus stenting, and then of course bariatric surgery. So those are the main ones that we have to choose from. So let's talk for a moment about transverse venous sinus stenosis. So this is one of the most reliable radiographic signs associated with idiopathic intracranial hypertension. And it's sometimes hard for us to know, does the transverse sinus stenosis cause high ICP, or is high intracranial pressure causing transverse sinus stenosis, or is it both? And so does one cause the other and then they reinforce each other in a feed-forward cycle? So it may be that the second model is more accurate, and some people have speculated that the venous sinus wall may be weaker in patients who have IIH, and so it's more susceptible to stenosis, and then that leads to high ICP, and then the high ICP causes more stenosis, and it causes this cycle. So in that case, how do we break that cycle? How do we break that cycle? So one way is to think about, well, what if we took care of this venous sinus wall weakness by placing a metal scaffold in there, like a stent? And so what we found is that some patients have a pressure gradient across their area of stenosis. And so if through catheter venography, we measure the pressure before and after the stenosis and find a difference of at least 8 millimeters of mercury, that's the criteria that's been developed and kind of supported most commonly to say that venous sinus stenting may be indicated. Now, the surgical treatment of IIH, there was a trial that was designed to try to look at that, and unfortunately, the trial was terminated due to low enrollment. So the surgical IIH treatment trial never happened. There is a trial that was possibly completed or may still be ongoing now, that's been going on for a few years, looking at, it's a prospective randomized controlled trial, and looking at patients who undergo venography, those with a transstenotic gradient of at least 8 millimeters of mercury, they were randomized to one of two arms, either getting a CSF shunt or getting venous sinus stenting. And so again, the primary outcome is going to be vision related, which is appropriate. And this was supposed to have completed in January 2024, which was a few months ago. And I haven't seen any publications or anything with this yet. So we're still waiting to see what results may come from that trial, and helping us know which might be more helpful for these patients. Would it be CSF shunt or venous sinus stenting? So the best data we have that compares the different surgical modalities for IIH actually comes from meta-analyses. And so I'll go over a couple of those here. One of these was a review of 20 studies. The majority of those were retrospective, and they had a varying number of patients, up to 52, even down to 6 patients in some of the studies, median follow-up about 18 months. They found that venous sinus stenting, for the most part, was quite safe. With 474 patients, there were only 3 that had subdural hematomas. 1 had a subarachnoid hemorrhage, and all of those completely recovered. There were some non-neurologic complications. 2 had a retroperitoneal hematoma. 2 had a post-op pseudoaneurysm. But overall, this supported a favorable safety profile for venous sinus stenting, about a 2% major complication rate. Here's another meta-analysis. This one looked at quite a few patients, over 1,000. So 712 had optic nerve sheath fenestration, 435 with CSF shunts, and then 136 with venous sinus stenting. And they compared the major and minor complication rates for these. And one thing that was important to note is that the highest major complication rate was seen in shunting. And so shunting is certainly not benign. And the lowest major complication rate was with optic nerve sheath fenestration, but venous sinus stenting was pretty comparable. And then minor complication rates, actually the lowest was with venous sinus stenting, and then significantly higher with the other 2 surgical modalities. And so the efficacy of venous sinus stenting in IIH has also been looked at in these meta-analyses. And if we compare some of the numbers from these, we find that papilledema improves in pretty much all of the forms of IIH surgery, but the best seem to be with venous sinus stenting. So about 94% of the patients in these meta-analyses had improvement in papilledema, whereas only about 70 with shunting and about 80% with optic nerve sheath fenestration. Also, the venous sinus stent patients got better with their pulsatile tinnitus. Their headaches got better, which is also true of shunting, not surprisingly. But optic nerve sheath fenestration is not a great treatment for headaches. So if headaches are a really big part of their symptom presentation, I usually don't send them for optic nerve sheath fenestration. And then the need for an additional procedure. The patients who were shunted, 43% needed another surgery at some point, whereas venous sinus stenting about 12%. So what does this mean for venous sinus stenting? Should we be recommending this a lot more? Well, the available evidence suggests that it has a favorable safety profile. It does improve headaches, vision, and papilledema, as well as pulsatile tinnitus. And so it could be that it's either comparable or superior to optic nerve sheath fenestration and CSF diversion like shunting. However, there's a big however here, and that is that these data that I just showed you are based on the pooling of heterogeneous data. So this is mostly retrospective. There's publication bias and other forms of bias. Cases with poor outcomes might not get published. And so the very long-term outcomes for patients with stents is really not quite clear. So that's why we're hoping for some of these prospective clinical trials to really help us know, is venous sinus stenting a good comparable way to treat patients who need surgical treatment for IIH? And so we're looking for those trials to help inform us here. But I used to not recommend venous sinus stenting at all. Now I do offer it as a treatment for patients, and I discuss this data with them and allow them to make an informed decision on their own based on what we know from the data. So what are our key points here today that I would like you to take home with you and really internalize from this webinar today? Well, one is that the prevalence of papilledema in patients with at least one radiographic sign of intracranial hypertension is very low. So only about 3% of those patients with a partially empty sella, for example, have papilledema. So we want to suspect fulminant idiopathic intracranial hypertension if someone has rapidly declining vision, if they have nausea and vomiting, severe papilledema, neck stiffness, and these are patients that need urgent medical and surgical intervention after the diagnosis is confirmed. So confirm the diagnosis immediately, and these patients need immediately need aggressive treatment. Vision is always the most important criterion when considering surgery for IIH. There may be other indications, but vision is always the most important one. And we just talked about what some of those surgical options are. Most patients with sulfa allergies tolerate acetazolamide just fine. So don't let a sulfa allergy talk you out of treating someone with IIH with acetazolamide if it's indicated. A very important one is IIH patients cannot lose vision without papilledema. It's safe to use acetazolamide in pregnant women with IIH when it's needed. Again, no reports of significant birth defects from acetazolamide. If headaches persist or worsen after other signs of intracranial hypertension have resolved, such as papilledema, then the headache should be treated phenotypically. So don't chase the pressure, the intracranial pressure in those patients. Get them to someone who can treat headaches and treat them phenotypically. Hormonal birth control, including oral contraceptive pill use, does not increase the risk of IIH. That is an old myth. IIH without papilledema poses no risk to vision, but it still be worth treating and diagnosing due to the other associated symptoms, and it can still help a patient feel better. The risk of vision loss correlates with papilledema severity and not the absolute opening pressure measurement. So in other words, it doesn't matter if their opening pressure is 45 or 27. Either way, it's high. The important thing is how severe is the papilledema. If it's very severe papilledema, those patients need more aggressive treatment. If it's less severe, then less aggressive treatment would be fine. The risk of kidney stones while on acetazolamide does not depend on the dose. So it doesn't matter if you're on a low dose or high dose. And the highest risk is within the first year and a half of therapy. So don't worry about keeping someone on therapy for years because of the risk of kidney stones. So if they're going to get the kidney stones, it'll be typically within that first year and a half. And the amount of weight loss that's necessary for remission of IIH varies in studies. It's been as low as 6% in some studies and up as high as 24% in the study I mentioned with the bariatric surgery in 2022. But regardless of how much the exact amount is necessary for remission of IIH, weight loss is a very important cornerstone of the management of idiopathic intracranial hypertension. Okay, so those are some of the key points that I hope you take home with you today. And there's a picture of my family who are very generous in supporting me to be here and do things like this today. So I appreciate them. And now I'll take some time for questions. So the question was asked, is acetazolamide safe in pregnancy and breastfeeding? So we talked about pregnancy. Yes, it is safe in pregnancy. There is some acetazolamide that turns up in breast milk as well. I haven't had many patients who have been breastfeeding on it, so I don't have a lot of personal experience with that. I would say I would still base that, I would still treat that the same way I would treat pregnancy, as if we don't need acetazolamide or it's necessary, I would try to keep them on as low dose as possible. If it's again a case with severe papilledema, that's something that I would still want them on acetazolamide. So even having a child on acetazolamide wouldn't be the end of the world for sure. So yes, I would still treat them with acetazolamide in that case. So question about who prescribes the Diamox. I think that just has to be worked out on a case-by-case basis. You can do it, or a neurologist can do it. There's no magic to it. It's a very easy medication to manage. I don't monitor any laboratory values while someone's on it. I just keep them on it, and I adjust it based on how severe their papilledema is and how their symptoms are, and side effects, of course. So question about how frequently I check potassium levels. I actually don't. I don't check potassium levels at all. And so I've been fine that way. Some providers I know do check potassium levels and may find them to be low at times. I've never found any critically low levels or any problems that have come from hypokalemia in the patients that I've had on acetazolamide. So similar question there. Let's see here. So what do you tell the patient when they ask things about high risk of developing kidney stones while on Diamox? So just as I mentioned in the lecture, so I tell them that the highest risk is within that first year and a half, and then it doesn't matter what dose we're on. I recommend that patients stay well hydrated, and then I just tell them that it's a rare side effect of the medication of acetazolamide. So I haven't had any patients who really want to not do the medication because of that, but it's definitely a consideration in patients who have a history of kidney stones. It's something that should be factored in to the discussion. So someone with kidney stones, would you change the medication or opt for decompression surgery? That can be one factor. So remember, one of the reasons to do surgery in patients with intracranial hypertension is if they fail maximum medical therapy. So if developing kidney stones prevents you from continuing the medication, then that could be failure of maximum medical therapy. So that could be an indication for surgery in the right patients. So here is a question about most patients come complaining mainly that their headache affects their quality of life. So how can we manage that in such a case? Well, again, you focus on the papilledema first, get that manageable. If that goes away and they still have headaches, again, treat the headache phenotypically. Don't chase the pressure. If that requires referring them to a headache specialist or to a neurologist, or even a primary care provider to manage the headaches, then so be it. Remember, the most important thing is to get the papilledema down, and that will help preserve the vision. Do you use acetazolamide in the first trimester? Yes, I do. So again, we have not had any reports of any significant birth defects from acetazolamide use. That being said, I don't indiscriminately use it. So if someone's in the first trimester, I still am cautious about it, and I only really do acetazolamide if necessary. If it's possible to kind of get through the first trimester without being on acetazolamide, I prefer that when it's possible. And so how long should someone treat a patient with acetazolamide? That depends on their symptoms and their vision status and how severe their papilledema is. If someone has at least moderate papilledema, then they really need to be on acetazolamide or some treatment for IIH. If they have minimal, like almost undetectable edema and they have no symptoms, then I might not have them on acetazolamide at all. I may just observe them clinically, and if they get worse, then I'll add acetazolamide. But I have quite a few patients where I'll have them, they're found to have very minimal disc edema, and they're really asymptomatic. And so those patients actually don't even treat with acetazolamide, even if they have IIH. So the endpoint of treatment for IH is really it's the papilledema for me. If the papilledema goes away, then that's time to get off the medication. So as an LP, always needed to diagnose IIH. Yes, it is part of the diagnostic criteria. However, there may be some patients where if you're not going to treat them anyway, then you can get away with just observation without an LP. That's only appropriate if they have no symptoms and they have very, very minimal edema. But those patients always need an MRI. You have to rule out a tumor or venous sinus thrombosis or some other structural cause. So if you've done that and they have minimal papilledema with no symptoms, sometimes you can get away without a lumbar puncture. What are the endocrine risk factors for IIH? Well, so the main thing has been obesity, but there's also growth hormone use has also been associated with intracranial hypertension. Is worsening of headache with posture a sign of raised ICP? So yes, it is. So if the headache is reliably worse when they lie down, better when they stand up, like immediately, that is usually a sign of high intracranial pressure. So how aggressively do you treat patients with IIH with a bilateral sixth nerve palsy? Well, so it depends on how debilitating the symptoms are. So if they are debilitated by the symptoms, then absolutely we want to get that to go away. If it's and so that would involve treatment with acetazolamide and kind of the same treatments we would use for IH with papilledema. So a lot of that'll be the same. Does the esotropia go away? Yeah, it usually does when the patient is treated appropriately. And so, yeah, I may titrate the medication up to help that go away or provide whatever intervention is needed to get their intracranial pressure normal. So the highest dose of acetazolamide that I feel safe prescribing is 2,000 milligrams twice daily. So a total of 4,000 milligrams per day is the maximum dose I go up to. So in stable IH patients, who monitors? So the neurologist or ophthalmologist, and how often would a visual field be performed, and what is the preferred visual field test? So for monitoring papilledema, that needs to be done by an eye doctor. So neurologists really aren't equipped to do that part. Neurologists can help with prescribing the medication if needed, or treating other symptoms, or treating headaches if they seem to be uncoupled to the intracranial hypertension. But ophthalmologists really need to be the one monitoring disc edema. So Goldmann visual fields can be done. That's fine. It doesn't. I don't think it matters so much what visual field test you use. I think the key is that you want to get a good sense for what their visual function is and whether it's worsening. Because if it's worsening, that means you need more aggressive treatment for IIH. If it's stable or getting better, then obviously whatever you're doing is fine, and you may be able to even de-escalate therapy. So it doesn't matter what visual field test you use. Just do something that's reliable, that you can interpret well, and know if the patient's worsening or not. So what surgical outcomes have the best, surgical options have the best outcomes? We talked about that in the webinar, but there's efficacy for all three of the different surgeries. So optic nerve sheath fenestration, CSF shunting, and venous sinus stenting. There are nuances that are different among all of those, and you can refer back to the recording of the webinar for a detailed discussion of those. What kind of imaging should we do with patients with IIH? So I always do an MRI of the brain with and without contrast as a minimum. MRV, you can consider if your MRI does not show the veins well. The MRIs we do here at Indiana University include thin cuts with a venous sequence, and so that's almost like an MRV, and that's sufficient to rule out venous sinus thrombosis. If you don't have that as part of your routine MRIs, then you may want to do a MR venogram, or if the patient has any red flags for a clotting disorder or family history of clotting or personal history of clotting, those may be reasons that I would opt for an MR venogram as well. How frequently does IH cause unilateral papilledema? I don't know the exact numbers for that, but I do have that in some cases. What's very rare is for it to be strictly unilateral. In more cases, I see that it's asymmetric. So it may be severe in one eye and mild in the other eye. I have a number of patients with that, but where it's really severe in one eye and pretty much none in the other eye is extremely rare. I'm not sure I've ever had a grade 4 or grade 5 in one eye and grade 0 in the other eye. I don't think I've ever had that happen. So what is the place for oral steroids and topiramate in IIH treatment? So I never use oral steroids in the treatment of IIH, even though it might help with the disc edema a bit. It causes too many other problems. It causes weight gain, it causes irritability, sleep issues. There's lots of side effects from steroids, and we have better medications to treat IIH than steroids. So I don't use oral steroids. Topiramate, I use if someone cannot tolerate acetazolamide, or if there's some other contraindication to acetazolamide, or they really need the weight loss help from the topiramate, or maybe they have a known history of migraine and that's part of the issue as well. So those might be reasons to use topiramate. Are there any options for drug-induced papilledema? Well, drug-induced papilledema, you treat the same way. The only exception is that really you want to try to get them off the offending medication if possible. So if you can do that, that would be great. If you cannot, then you treat it the same way as you would any other case of intracranial hypertension with medical management and surgical management if necessary. Can you talk about age and gender prevalence in IIH, please? Yeah, so about 95% of patients with IIH are women. And then as far as age, we typically treat it or consider it a condition of women who are in their childbearing years. So usually that's teenage years, most commonly after puberty, up to maybe their 40s or 50s for most women. There can be exceptions to that, but that's the typical kind of age distribution I see. Labs need to be monitored while on Diamox. No, again, I don't monitor any labs while on Diamox. I know some people do. I don't. Patients commonly develop a metabolic acidosis while on Diamox. That doesn't matter to me unless it's a problem for some other condition that the patient has, or if they're miserable from the symptoms of a metabolic acidosis. Otherwise, again, I don't monitor any labs while patients are on acetazolamide routinely. How often to do the visual fields depends on how severe the papilledema is. So if it's really, really severe, you want to do the fields more frequently. If it's less severe, then less frequently is fine. And you'll have to figure out exactly what that frequency is for your clinic and your practice. Can IIH occur below the age of 16? Absolutely. Yep, it can occur in children. It can even occur in prepubescent children. And in that group, it's interesting. It actually doesn't have to be associated with obesity in kids who are before puberty. So yes, that does happen. So someone asked about what to do with papilledema IH without papilledema. And if there's a progressive increase in nerve fibers on OCT, then that means that they have papilledema. So again, if they have papilledema without raised intracranial pressure, then I think you're talking about something else. You're talking about optic disc edema and some other condition, and so that would not qualify as IIH. Is it worth doing an LP on a patient with resolved papilledema on treatment and recurrent headaches? If it would change your management, yes. So if you find that the pressure is high, that might be a vote that you could still try treating the intracranial hypertension and see if that makes the symptoms better. But if their papilledema is gone, I usually don't repeat a lumbar puncture because at that point there's no risk to the vision. So I would again treat the headache phenotypically or send them to someone who will treat the headache phenotypically. The role of intracranial venous sinus stenting was discussed in the webinar, and so I'll refer you back to the recording of the webinar for a detailed discussion of that. Question about who performs optic nerve sheath fenestration. It sounds like in Croatia there is ophthalmologists are not trained in optic nerve sheath fenestration, and then neurosurgeons don't do it either. Yes, it would be an ophthalmologist that would do it. Here at our institution, it's a subspecialist, an oculoplastic surgeon. They're the ones that do optic nerve sheath fenestration. So if you don't have that in your country, then you would be limited to either CSF diversion like a shunt, or venous sinus stenting or bariatric surgery. So you just wouldn't have the optic nerve sheath fenestration as an option. And that's going to be true at other institutions as well. You may not have access to all of those options, in which case, okay, you just do the best with the options that you have. So the definition of papilledema is optic disc edema from raised intracranial pressure. That is the definition of papilledema. Question about, should we treat a kid with radiological signs of IIH imaged for acute onset esotropia, but totally asymptomatic without papilledema? So I would not treat that patient for intracranial hypertension just based on that, because again, a lot of these patients are not going to have high intracranial pressure. So I would treat the esotropia if applicable. If it's changing or there's other signs that would suggest high intracranial pressure, then that's where a lumbar puncture may be indicated. But otherwise no. How long can a patient be on acetazolamide? They can be on it indefinitely. As far as how I stop it, I kind of wean it off. There's not any huge effect or huge like downside to stopping it kind of suddenly, other than it's possible for their disc edema to recur if you have them on a fairly high dose, and let's say they have minimal edema or no edema. If you stop it all abruptly, it's possible that the edema may come back. So I tend to wean it off a little bit, maybe over a couple of months. And if they're already on a really low dose, I may just cut it off altogether or just do a very short taper of the medication. So have you ever seen a case of IH progressing after a VP shunt? Yes, that has happened in some cases. And so in those cases, if you fail one modality of surgery, you still have the other modalities that you could do depending on that specific case. So yes, that does happen. A question about drug-induced IIH. Principle number one is try to get them off the offending drug. And if you can't, or even if you can, and there's still IIH left over afterwards, then you would treat it as you would any other case of IIH. Okay, and then a question in Spanish. So let's see how I do with my Spanish. Recomienda estudios de radioimagen simples o contrastes o con contraste. So I think it's about recommending contrast for radiographic studies. So yes, when I'm screening for structural causes of intracranial hypertension, I recommend an MRI of the brain with and without contrast. I do that. That helps me see venous sinus stenosis better, and also if there was a tumor or other abnormality that may be more difficult to pick up without contrast, the contrast definitely helps me for that. So the histologic changes in thin transverse sinus postmortem compared to a normal one, I don't know. I don't know if that study's been done, so that we'd have to look at the medical literature for that. So as far as opinion for VP shunting, so it has its drawbacks and advantages. One of the drawbacks of CSF shunting is it has a higher complication rate and a higher need for surgery, like repeat surgery again in the future. So you have to be careful with that. However, it is very effective in a lot of cases, and a lot of surgeons know how to do it, and it's a fairly simple surgical procedure for surgeons. So it can be helpful if it's needed. But again, I'll refer you back to the webinar for a more detailed discussion of how it compares with the other modalities. What would be my first line surgical management of shunt versus optic nerve sheath fenestration if both are available? Factors that help me with that are, do they have headache? And so if they have a bad headache as part of their symptoms for IIH, then I'll probably not do an optic nerve sheath fenestration because that won't help much with the headache. I would probably opt for a shunt. And if it's mostly papilledema and they don't have much other symptoms, then I'd probably prefer an optic nerve sheath fenestration. So that's a basic way that I help distinguish if I have the option of doing either one. So let's see here. Asked after IIH diagnosis confirmed, medication of acetazolamide started, and then the follow-up timeline schedule recommended. So yeah, that's really going to be dependent on everyone. I think you have to get a flavor for that yourself, and I can't tell you exactly how often you need to see these patients. There's just so many factors that go into that. As far as what you check on, yeah, you check on symptoms, you check on visual acuity, optic nerve function, so color vision, visual field testing, and then you have to do a fundoscopic exam and see how severe the papilledema is. I like to use OCT as well. That's very helpful if you happen to have that as well. So very often papilledema doesn't go away even with normalized intracranial pressure. Well, if that's the case, then you might not have the right diagnosis. In the cases I've had of IIH, when the pressure goes to normal, the papilledema goes away. So that may be a different entity if it doesn't go away. What is the recommended loading dose for methylprednisolone for surgical management in fulminant IIH? There's not data to really answer that question, but what I would do is 1,000 milligrams of IV methylprednisolone, and that you may do for a few days, kind of similar to what you'd do for an optic neuritis flare or something like that. And let's see here. What percent of development of multiple sclerosis from IIH? IIH is not related to multiple sclerosis, nor is there a risk of one of the conditions causing the other. So those are completely independent conditions. In a case of daily vomiting, would you go with IV or still oral? So Yeah, so IV's hard, right? Because you got to be in a hospital, or you'd have to have a PIC line or something like that in. So if their vomiting is that bad, that might be a sign that they need to be an inpatient and figure out, okay, why is this so bad? Is it because their ICP is super high? If so, then maybe that's something where we need to intervene more quickly on that patient, especially if they have severe papilledema. So someone like that might even need a surgical intervention. It's kind of hard to say just from that question. We'd have to take it in the context of the actual case. How often should one serialize eye examination appointments? Yeah, so again, about how frequently to examine, that's really going to be up to each individual provider. I can't give you an answer for exactly how often you need to see these patients. If the discedema is super mild, I'll tell you what I do. If it's super mild, I might see them once every 6 months, and they're stable and they have very minimal symptoms. If I'm worried about them, then it's going to be more like, I might see them in a month or two, or maybe even a number of weeks if it's a especially severe case. You want to get enough time to pass so that your interventions, you can know if they're helping or not. But you also don't want so much time to go by that if they're worsening, that you cause any permanent damage. So that's the main principle that decides how often they need to follow up with you. So a question about the role of visual evoked potential testing to monitor treatment. No, visual evoked potential testing I have not found to be useful for this. I suppose it could be useful if you don't have OCT and you don't have, trying to think what else, maybe if you didn't have visual field testing for some reason, but did have VEPs, it would be a very kind of specialized set of circumstances where VEP could be helpful, but I don't use that. So question about the role of intracranial venous sinus stenting. I'll refer you to the webinar for that, where there's a detailed discussion of that. Is there any special attention to be aware of in treating IIH in children cases? Yes, so that's a great question. So yes, probably one of the most important things is that kids are not as reliable with their symptoms. And so part of that's because they just don't know how to articulate their symptoms. And so that can be really tricky. So we have to be really in tune to that. But otherwise, the other principles are the same about the severity of papilledema and the function of the vision and their visual field test and those things. If they can do them, those are what are going to play a role in how to treat the patient. If they're so young that you can't even test vision on them, then you really have to go by what you know about the symptoms and how severe the papilledema is. Let's see here. And then can enlarged cisterna magna be a radiologic sign of intracranial hypertension? That has not been found to be a common one. I can't speak to whether there may be some cases where that's the case, but in general, no, that's not something we look for as a sign of intracranial hypertension. And then the physiologic explanation for weight loss as IIH management. So there's been a lot of kind of metabolic research that's been done recently looking at different signaling factors and hormonal pathways, and some of those have an intimate relationship with adipose tissue. And so there are some reviews that have been published on that. Alex Sinclair's group has been one that's been active in that research, and so I'd refer you to them. There's been a few reviews done over the past few years that talk more about that. If we see papilledema, but the patient doesn't have any symptoms, as an LP mandatory. So again, if it's at least moderate papilledema, then yes, it is mandatory in my estimation. If it's minimal papilledema and they have no symptoms, and you've had an MRI that shows no tumor or serious structural cause, then that kind of a patient may be okay for not doing a lumbar puncture. Can topical steroids cause IIH? I have had a few patients where we think that topical isotretinoin use may have provoked IIH. I don't think I've seen any cases of topical steroids, though, leading to IIH. Do you rely on retinal nerve fiber layer thickness for corroboration? Absolutely. So I definitely use OCT and measure the retinal nerve fiber layer thickness as part of all my visits, and it's a very helpful quantitative measure that helps me follow someone's severity of their disc edema. It always has to be paired with the visual field exam, though, too. So I always do both. How often do you increase the Dimox? That's going to be a case-by-case basis, and really depends on how severe the optic disc edema is and how severe their symptoms are, and a lot of factors go into that. Some patients I'll go up real quickly over maybe a week or two, up to whatever dose I think they need to go to, if sometimes even a maximal dose. And if it's more mild, then I would just kind of change it when I have a visit with them. And if it seems to be worsening a little bit, then I'll go up a little bit. So it's kind of like that. So the highest dose I use, again, 2,000 milligrams twice a day is the highest dose I go up to when necessary. And I start reducing when the patient's edema is getting better or if they're having significant side effects. So if their edema is really minimal, that's usually when I'll feel comfortable going down on the medication. Prognosis of IIH, is it different in men and women? There has been a research that suggests that the prognosis may be worse in men, and part of that may be for a more advanced symptom presentation and sometimes even more advanced vision loss on first presentation for men. So that could be one of the reasons for the difference there. Lately seeing few cases of suspected IIH in young people who have been prescribed large doses of vitamin A for acne. Yes, absolutely. That is definitely an association. So I often ask that in my review of systems for a patient with high intracranial pressure, or I think may have that. I ask them if they're on any medications like isotretinoin or anything that may be a vitamin A derivative, because yes, that is associated with intracranial hypertension. How reliable is the LP opening pressure? I find it's pretty reliable if it's done by a person who knows what they're doing. Otherwise, it can be tricky. I always use it as one factor. So if everything suggests that the patient has IH and their lumbar puncture was, not done properly and it didn't show high intracranial pressure, I won't let that prevent me from treating the patient. But in general, the LP opening pressure results should agree with their symptoms and with their optic disc appearance, and it should all make sense. So can LP be done together with methylprednisolone and Fulminant IIH? Yes, it can. And about age again, what is the youngest and oldest patient I've encountered? So I don't usually see children, so I'm probably not a good one to ask about the youngest. I have had patients in their 60s with intracranial hypertension. I'd have to look and see if I've had any in their 70s or 80s. I don't remember off the top of my head, but I've definitely had patients in their 60s with it. Any relationship with systemic hypertension? Probably not directly. We haven't found a good link between systemic hypertension and intracranial hypertension. There is, as you know, systemic hypertension is exceptionally common, and intracranial hypertension not as much. So we really haven't seen a good link between those. So comment on a case of a young female, 15 years old, tall and skinny with mild evidence of papilledema and some headaches, imaging studies, LP, other investigations. So anyone who has papilledema needs neuroimaging. That is a non-negotiable one. So everyone needs neuroimaging if you think they have papilledema. If it's minimal, like really, really minimal, and they have normal vision and no symptoms, then the LP might be optional. If, however, you're still concerned that it might not be IIH, let's see, maybe they have a meningitis or something else you're concerned about, then the LP would still be indicated for those reasons. Always be suspicious of someone who is not obese and you think has IIH. Always think about, could there be some other secondary cause of intracranial hypertension in those patients? So as far as what signs to look for on OCT for IIH and for papilledema, we look, of course, for thickening of the retinal nerve fiber layer. That's the most important one. I'll also look at the pattern of the thickening. The thickening should typically be nasal, superior, and inferior to start with. And then as it gets more severe, it'll involve the temporal part. If I see what looks like edema or there's thickening and it's only temporal and it spares all the other quadrants of the disc, that's going to be very atypical for early papilledema, and that would make me think about other causes. How long does it take for papilledema to disappear after control of ICP? Yeah, that's a really good question. I think it depends on the severity of the papilledema. If someone has really severe papilledema, it actually takes a few weeks for the papilledema to go away. I've even had cases where it might even be up to a month or two. If the papilledema is pretty mild, then it can go away very quickly, even probably within a matter of days to weeks. Yeah. And then spontaneous venous pulsations, can they exclude high intracranial pressure? Very good question. So there have been studies looking at this, and the answer is pretty much all patients, if they have an intracranial pressure of greater than 30 centimeters of water, they will not have venous pulsations. There are some patients with an opening pressure on LP between 25 and 30 who may still have venous pulsations, but they don't have, they may still have venous pulsations, but they still have high pressure in the head. So those are the tricky ones, and that's why venous pulsations are not perfect in predicting whether someone has normal pressure or not. Let's see here. And then the role of B-scan for measuring optic nerve sheath diameter. I usually don't use that. If you have a really If you are very proficient with ultrasound or someone you know is, then that might be helpful. I wouldn't use that though. OCT is much better for getting the information we need for IH management, and then again, visual fields. So I really don't think you need to do anything else other than those two things and an eye exam with the basics. Relationship with PCOS, polycystic ovarian syndrome. Yes, IIH. I do have a lot of patients who have PCOS and IIH. So yes, there does appear to be a link between those. Let's see, the etiological spectrum of pediatric IIH. So I mentioned that a little earlier. The patients who are prepubescent, so before puberty, they may not be obese. Also, the gender difference, there appears to be no gender difference in patients before puberty. So boys and girls are about equally affected before puberty with IIH. Question is, OCT angiography useful in grading? I have not found a clinical use that is good for OCT angiography in IIH. So I just use normal OCT and measure the nerve fiber layer thickness with the OCT. What parameters does one look at with an OCT for IIH? So I look at the retinal nerve fiber layer thickness, especially in comparison with other exams that I've done or someone else has done. And then I also look at the ganglion cell analysis. The ganglion cell analysis can sometimes give us a clue that there's been some damage that's happened to the optic nerve, even before it would show up on the retinal nerve fiber layer thickness. Because think about it, if you have swelling and let's say there's some atrophy developing, the nerve fiber layer thickness will still be thick. So you don't know that that atrophy is there unless you're also doing visual fields. And you could tell if the ganglion cell analysis shows thinning there, then that could be a sign that, okay, we're starting to deal with some atrophy here. All right, well, those were some wonderful questions. Thank you very much, everyone, for joining the webinar. And I look forward to seeing you on a future webinar.